Hello, my name is Mustafa and I'm a medical doctor, and this is a high quality free medical online resource for you to learn nephrology. It is going to be a series of videos. Please like this video so it reaches more people, and in this video of the nephrology series we will talk about the minimal change disease. So this is one of the diseases that causes nephrotic syndrome, and it is characterized by edema, like the pitting edema in this picture, and the proteinuria also. So let's start with an overview to the minimal change disease. So it is one of the primary glomerular diseases that lead to nephrotic syndrome. As we mentioned, the MCD is the most common cause of nephrotic syndrome in children. It accounts for 90% of nephrotic syndrome cases in children younger than 5 years and 50% of nephrotic syndrome cases in children older than 10 years, and between this number for children aged from 5 to 10. The minimal change disease accounts for 10 to 15 of nephrotic syndrome cases in adults. Also, the MCD has good prognosis compared to other causes of nephrotic syndrome. Now let's talk about the causes of the minimal change disease. So we have primary and secondary types of the MCD. The primary is idiopathic, and the secondary is secondary to drugs like NSAIDs, antimicrobials, and lithium, or neoplasms like Hodgkin's and non-Hodgkin's lymphomas, leukemias, and thymoma, or secondary to allergy like atopy, vaccinations, insect stings, and foods, or secondary to viral infections like the upper respiratory tract infections. The primary disease might relapse after exposure to one of the secondary causes. Now let's talk about the pathogenesis of the minimal change disease. So it starts by an immune attack initiated by the T cells against the podocytes for unknown reason. So the T cell would attack the podocytes, and this would lead to T cells injuring the podocyte photoprocesses, leading to effacement of these photoprocesses. And as we know, the photoprocesses are forming the filtration slits, and when they are injured, the filtration slits would be larger, allowing proteins molecules to cross and subsequently cause nephrotic syndrome. So this is a simplified drawing for you to understand that. So here we have the capillary membrane, or the glomerulus capillary membrane, and here we have the glomerular basement membrane after, and then we have the podocytes here. We have three of them in this drawing. Those are the filtration slits between the podocytes, this one and this one. We have two of them here. And what happens is that the fluid in the blood is coming through here. This is the blood side in the glomerulus, and this is the filtrate side. Filtrate. So what happened in the minimal change disease is that the photoprocesses of the podocytes here and here are damaged, so the filtration slits would be bigger than normal. So they would pass larger molecules that normally doesn't pass, like the proteins. So we would have proteins here in the filtrate, and this would lead to proteinuria and nephrotic syndrome. If we take a renal biopsy from a patient with minimal change disease, we find out that the light microscopy examination of the biopsy is normal, and that is why it is called minimal change disease, because the light microscopy is normal when examining a biopsy from the kidney, and the immunofluorescence is also normal. The difference is in the electron microscopy examination. We find out about the effacement of the photoprocesses, we find out about the microvilli and the vacuolations on the electron microscopy. So this is here another simple drawing to show you what happens when you look in the electron microscopy for the glomerulus. So this is here the capillary of the glomerulus, and this is here the basement membrane, and those are the podocytes, and those are the photoprocesses of the podocytes. And what happens is that you see that there is diffuse loss of the photoprocesses, allowing larger molecules to pass through them, like the proteins. And also you can see the microvilli and the vacuolations. The vacuolations being small vesicles, and both of those, the microvilli and the vacuolations, are not seen in the normal podocytes. It's only seen in the minimal change disease. So again, in electron microscopy, you see a diffuse loss of the photoprocesses, the microvilli, and the vacuolations. Now regarding the pathophysiology of the minimal change disease. So the MCD lead to proteinuria, which is the froth urine, as we mentioned earlier. And this will lead to decreasing the serum protein. One of the protein lost is the immunoglobulins, and those are related to immunity. So when they are lost, this would make the patient more susceptible to infections. But the immunoglobulins lost in minimal change disease are far less than the other types of diseases that causes nephrotic syndrome. So the patient with minimal change disease would be less susceptible to infections than other causes of nephrotic syndrome. Another proteins are the coagulation factors. Those are lost too, and the anticoagulation are lost too. One of the anticoagulation loss is the antithrombin 3. The antithrombin 3 is responsible for deactivating the active forms of factor 2, factor 9, factor 10, factor 11, and factor 12. And if this lost, this will lead to increase the susceptibility to coagulation and subsequent thrombosis. As a result of the protein lost and decreasing the serum protein, the liver would react by producing more proteins and lipids. And this would lead to hyperlipidemia and fatty casts in the urine. So your patient would have hyperlipidemia and fatty casts in their urine. One of the proteins that is lost in urine is the albumin. And this is the major protein that forms the oncotic pressure. So we have two types of pressures. We have the hydrostatic pressure and we have the oncotic pressure. The hydrostatic pressure is responsible for pumping the blood inside the circulation, and it is formed by the heart. The oncotic pressure, on the other hand, is responsible for keeping the fluid inside the circulation. And once the oncotic pressure is lost by losing the albumin, this would lead to edema. The fluid would displace from the intravascular and into the tissues. So the tissues would have the fluid in them, and this would lead to edema. And as a result of the fluid shifting, this would also decrease the intravascular volume, which lead to activation of the renin-angiotensin-aldosterone system. This system is activated by the kidney once there is low volume inside the circulation. And when this activated, this would lead to hypertension and sodium and water retention in order to get the pressure or get the volume back to the normal levels. And this would also aggravate the edema. So this is the pathophysiology of the minimal change disease and nephrotic syndrome as a whole. So there would be infections, thrombosis, hyperlipidemia, fatty casts in urine, edema, and hypertension. Now let's talk about the presentation of the nephrotic syndrome. So this disease is present with the frothy urine, meaning high protein in urine, and also edema is the first sign, and it is pitting and it is worse in lower extremities, and also there would be periorbital edema. Like this child here, you can see that there is edema around their eyes, which is called periorbital edema. There would be also abdominal pain due to ascites. Ascites form because of the same reason of the oncotic pressure. Once it decreases, this would also lead to fluid being displaced into the peritoneum, and it would cause ascites, severe hypovolemia, peritonitis, pancreatitis, thrombosis, or steroid-induced gastritis. So your patient might present to you with abdominal pain due to these causes. There might be also hypertension. Your patient may also develop white nails, sometimes in bands, which is called the Merkes lines during relapses. This is a picture of them. You can see that there is multiple lines in the nail, and the area between the line is white. They are called murky lines. Adults may develop xanthomas and xanthelasmas because of the hyperlipidemia. This is a xanthelasma like you see here. Now let's talk about the diagnosis. So there would be nephrotic range proteinuria. The urine dipstick test would show 3 pluses or 4 pluses. The 24-hour urine protein is more than 3.5 grams. The urine protein creatinine ratio of more than 3. And the comprehensive metabolic panel looking for hypoalbuminemia would show hypoalbuminemia of serum albumin less than 3. The renal function tests, which are the blood urea nitrogen and creatinine, you look for renal dysfunction using them. And you would also send for serum electrolytes, looking for calcium and other electrolyte changes, because the total serum calcium and vitamin D decreased due to decreased protein-bound calcium and decreased vitamin D binding proteins, which are lost in urine. Because those proteins are lost in urine, the bound part of the vitamins are decreased because of that. But the enhanced calcium mostly normal. Sometimes there is mild hyponatremia during relapses. There might be elevated hemoglobin and hematocrit levels, and thrombocytosis are usually found in MCD patients during relapse as a result of plasma volume contraction. Once the plasma volume contracts, the hemoglobin and hematocrit would elevate. And confirmatory test is with renal biopsy. Finally, let's talk about treatment. So the children younger than 10 presenting with idiopathic nephrotic syndrome, the biopsy is not indicated, and you treat them like they have minimal change disease. Because remember, the studies shows that a lot of them have the minimal change disease, so the biopsy is not indicated. Children younger than 10 presenting with features does not go with minimal change disease like gross hematuria, renal dysfunction, then renal biopsy is indicated. And children older than 10 and adults, the renal biopsy is always indicated to establish diagnosis. The curative therapy is that the MCD responds very well to corticosteroids. The corticosteroids are used in high doses for 12 to 16 weeks, then tapered over 6 months. The cyclosporine for steroid-resistant patients, and the cyclophosphamide, the mycophenolate mofetil, or rituximab for steroid-dependent patient. Relapse if steroids are stopped. So the steroid-resistant patient is the patient that doesn't respond to steroid. You give them cyclosporine. The steroid-dependent patient is the patient that depend on steroid. If they stop the steroid, they would relapse. So you would give them one of those agents, either cyclophosphamide or mycophenolate or rituximab. And of course, you use the supportive therapy in form of blood pressure management. It should be less than 13/8, using ACEs or ARBs, hyperlipidemia treated with statins, edema treated with sodium restriction and diuretics, thrombophilia treated with anticoagulation, and infections treated with antibiotics, and so on. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe. And if you want to support us more, you can by subscribing to the Patreon, link provided in the description of this video. Thank you for watching, and peace.